Existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture, and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957. Today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang, make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society, nowadays UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, postgraduate school. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Pajajaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities, such as library, Basic Science Service Center, Language Center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Pajajaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Pajajaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Pajajaran, straightening and developing together with society, from West Java, for Indonesia, to the world, through SDGs.
Well, that was our college, and we really hope that maybe one day you can visit us and give us live lecture, maybe after the pandemic over.
This for free while gaining great.
That would be my pleasure.
For
Real pleasure.
Faculty of Dentistry, Universitas Pajajaran, and smart friends.
Okay, Dr. Dian and Dr. Onah, let me open this session for you. Greetings from Transcendent
Okay, please.
2021. Massive open online course in cleft lip and palate by Faculty of Dentistry, Universitas Pajajaran, in collaboration with Smaltran and YPPCBL, has been going on few weeks for today. My name is Alain Tan. I am student from Faculty of Dentistry, Universitas Pajajaran. So I see that we come from different countries. I think it's appropriate for me to say good morning, good afternoon, and good evening for everyone here. Also, greetings to Dr. Ifeanyi Onah from National Orthopaedic Hospital Enugu, Nigeria. Thank you for being here, Doctor. It's been an honor for us. We really appreciate your presence here. So, how are you, Dr. Onah?
I'm fine. How are you?
I'm fine too. Thank you for giving your time here, Doc. Hope you are doing well and stay healthy. Also, here we have Dr. Gigi Dian Maifara, Spesialis Bedah Mulut from Universitas Pajajaran as our moderator today. Thank you, Doc, for being here. How are you, Doc?
Fine. Thank you for having me.
Okay. Also, greeting to all of the participants. Thank you for participating in this course, and thank you for attending this live discussion sessions. So, doctor and participants, today is our first live discussion in third week. On the previous discussion, we already learned about the basic knowledge about cleft, also nasoalveolar molding, and nose revision surgery. For today, we are going to discuss more about bilateral cleft lip repair by Dr. Onah. And this live discussion will be separated into two sessions, which is in the first session, Dr. Onah will answer the questions that have been collected by the participants in the MOOC website. And then in the second session, the participants here will have opportunity to ask the questions either directly or maybe by the chat. So don't forget to write down your question and your name for participants who want to ask by the chat. And after this session, don't forget we're gonna jump right into the other session. So don't forget and just stay tuned. So without any further, I will let Dr. Dian to be the moderator of the session. Time is yours, Doc.
Okay, thank you. Okay, we can start. Okay, Dr. Onah. There's so many questions, so some of the question will share by the screen, and we can start live discussion immediately. Okay, we have the first question. The first question is from Mutiara Azahra, is our student in Universitas Pajajaran. She asked that in the lecture, it is said that orthodontists are disturbed by active pre-surgical orthopedic device, such as locum. Does that device that yields a passive molding, such as NAM, could also have negative impact on the maxilla? And what is the best pre-surgical orthopedic device for patients with bilateral cleft lip and palate? Well, what do you think, doctor?
These are things that are still evolving in terms of looking at their long-term outcomes. So the term, the best pre-surgical device, may not be the correct way to put it. I think that when we look at bilaterals, they help with narrowing the alveolar cleft, but sometimes it appears we get too much tissue when we use them. What we do here is strapping. We just strap, knowing that by the time we get the muscle across, because in the bilateral repair, you get the muscle across in the midline, it over time molds the maxilla, and you have something good. Even the rotational aspect is corrected over time. So I don't know what we would say is the best device with for patients with bilateral lip and palate, but I think we should take it a little at a time. We do more of strapping here. We don't do so much of the latham device in our environment.
And for your patient, what device that you use the most?
My orthodontist may be better suited to know the one she uses the most, but I don't do them. We send the patients for orthodontics to the orthodontist. But I think that what she does more is using strapping for the lip, just strapping. It's simple, it's a modest improvement, but it's good. And then when we do the repair, especially if we're able to do it early, the muscle itself brings about the natural molding. So lip taping with plaster is what I think she does most. I've not seen her using the Latham device.
Okay, so the simple one, yeah?
Yeah, the simpler, the better.
Okay. Okay, well, the next question. The lecture showed that bilateral cleft lip and palate case are more common in male. What do you think? Why is that happening?
Well, when you look at the population of people tends to be slightly more male. And even when you look at cleft lip and palate, it's just the isolated cleft palate that is more in females. I don't know why it is said to be more in males. I don't know. These are things that we will need to explore, see if any of the genes that brings about the expressivity of bilateral cleft is somehow carried more in the Y chromosome or not. We don't know really why, but perhaps these are things to inquire, explore, and find out.
Yeah, maybe because the chromosome, yeah, maybe. Next question, please. Can you elaborate more why the surgery is best done in the morning?
In the morning, we find out that most of the team is alert, available, and we also have fewer complications occurring there. Most places that have been, the surgeries are preferably done in the morning. Now, when you operate at night, you tend to operate when you are tired, you are not as fresh, and the tendency for errors, both clerical errors, surgeon errors, anesthetic errors, and oversights are much higher. So it's best done in the morning for the sake of the team. Usually the team is better able to give the best to the patient at that time.
So it depends on the team, the operator and the assistant and all the team members. So they become more alert in the morning, so the result will be better.
Yeah.
Okay. Well, the next question. Next question is from Rashid Abdul Aziz. He asked that, I have seen a literature mentioning that modified Millard technique also provides excellent surgical outcomes, like less scar formation, symmetrical nostrils. What are the advantages of Tajima closed rhinoplasty that you are currently using compared to this technique? Does the surgical outcome has always been the parameters in deciding a good or preferable surgical technique? Thank you so much. What do you think, doctor?
The advantage of the Tajima is that the interference is less. Now, once you interfere, the more you interfere, the more there is scarring. And whenever there is scarring, longer term results are not as good. The surgical outcome is important when we look at surgical techniques. We can't look at techniques without looking at outcomes. And when you look at outcomes, you look at what happens today, you look at what happens to the patient when he's in the teenage years, you look at what happens to the patient much later. And those are the things that you look at. So if you look at the bilateral, you will have to remember that the bilateral has different components. There are some in which the columella is very short. There are some in which you just have a microform. So when you are looking at the Millard modification and you're looking at other techniques, you have to put into consideration, are you looking at it for every bilateral or just some forms of bilateral? In my own limited practice, I have found the Tajima to be the most effective because in terms of aesthetics, in terms of time that we do the surgery, and in terms of scarring, it has shown me to be the best so far. That's my own experience. Perhaps others will have a different experience, but that's been my experience.
Thank you, doctor. So Tajima is the technique that you use the most for almost all of your bilateral patients.
Yes, I used to use the Cronin V2Y, but it introduced an unnecessary scar, and long-term outcomes to me were not so satisfactory. When I started using the Tajima, I started having better outcomes, more satisfaction on the longer term. So I encourage it.
And do you think that Tajima have a negative or disadvantages from Tajima technique? What do you think? Have you ever dealt with a negative result from Tajima technique that you use for your bilateral patient?
Not yet, unless I have not executed it well. Any technique that you don't execute very well can have some negative property. But right now, I don't remember one that has had some negative outcome, unless I didn't execute the Tajima well. There, like I pointed out, there are some, when I look at the columella, I think I can leave it alone. So I don't do Tajima, I don't do Millard, I don't do Cronin, I just leave it because I see that after some years, the patient, it's okay. But I have not had any negative with Tajima so far, no.
Okay, thank you, doctor. Okay. Well, is that the last question we have?
Yes, doctor. Now we are open to our participants here. If there is something to ask to Dr. Onah.
Okay, please, for the participant, you can ask directly to Dr. Onah. It's a very great lecture that he had gave us.
There is a question in a chat box, doctor. Can you see it?
Okay.
Dr.
This question is from Andrew Lauren, and he asked that what kind or brand of lip tapping do you recently use for cleft lip patients?
Yes, the tip we use is the one that has little allergy, hypoallergenic tape. It's usually white, and we teach the mothers how to apply it when it has gone off. So it's the hypoallergenic tape, because some of the plasters that are used can bring some reaction to the face. So it's the one that doesn't bring a reaction to the face that we recommend and use. And we teach the mothers how to use it as well.
Okay, doctor. Thank you for the answer. There is still a question in the chat box. How about the Nordhoff technique in your experience, Doc, from others?
The Nordhoff for elongating the columella, I have used it once. I think the Nordhoff should be used where you have enough tissue. It's more difficult to execute. If you are dealing with babies, I think you will have to have magnification, and you will have to rest your elbows properly on a rest so that there will be little tremor as you execute it, because you have to be very careful not to transect the blood supply. I think it's a nice technique. It gives you a good projection, but I believe you should use it when you have enough tissue. So if you're doing bilateral in an adult or in an older child, it's something you can use, but you must be careful with it. That's my thoughts on the Nordhoff technique.
Okay, thank you very much, Doctor.
Okay, Dr. Dian and Dr. Onah, maybe this is the end for our session. Maybe there's something you want to say before end this session.
Yes, be encouraged. The bilateral repair can actually result in excellent outcomes, and the symmetry can actually be better than what you find in unilateral lips. But you must have careful attention to detail and do it at the time you are freshest. Thank you very much.
Thank you very much, Dr. Onah.
Okay, I think that was the end for bilateral cleft lip repair. It was a great opportunity for all of us hearing the valuable knowledge from Dr. Onah. And also here we have Dr. Dian as a moderator. Thank you so much for Dr. Onah and Dr. Dian. In these hard times during the pandemic, we can still find the bright side that we can still meet here through the online course. I believe this would be an inspiration for all of us to learn cleft lip and palate more and more, even further to implement the best treatments to our cleft patients. Before we end today's session, once again, I would like to say thank you so much to Dr. Dian, Dr. Onah, and also the participants here. Okay, this is the end for the first session. Now we are moved to the second session.
Thank you for having me. Appreciate it.
Thank you, Doctor.
Thank you very much, Dr. Onah.
Thank you. Bye-bye.
Thank you so much, Doc.